suicide trials, about 30% of the patient, more than one. Yes. Yes.
So we still have some time, and I will ask you another question, sorry. But you mentioned that this is an agricultural area, and that's why your organophosphate is high in the list. But access to this material also may be affected by the people who's moving from their houses and living in displaced area. That's maybe an important element. You mentioned that you took the age of 14 plus, that's the adult population. So in the pediatric, do you find higher percentage?
The hospitals which are conducted in this study was internal medicine hospitals, not pediatric hospital.
Excellent presentation. Thank you very much. I really applaud the work you've done. Thank you.
Yeah, thank you. I got, it's okay. Thank you very much. The next presentation is on ethylene glycol intoxication. So in Amsterdam, where we work, we see lots of recreational drug intoxications, of course, mostly after parties. There are some, as I told you, lots of suicide attempts. And Siham is going to present a case of ethylene glycol intoxication. And Siham is one of the up-and-coming doctors in our hospital. She's doing a PhD on immunology and hopes to do probably specialize in internal medicine or emergency medicine or something else later.
Oh, thank you. It's this? Yeah, it works. Welcome, everyone. My name is Siem Azov. Thank you, Professor Prabhat Nanayakara, for introducing me. I'm indeed a PhD candidate at the Department of Internal Medicine. And today I want to share a diagnostic trick with you. But not before I thank the organization for hosting me today and providing me the opportunity to speak. So let's get started. Imagine you're in the Netherlands. That's why we have yellow ambulances. You're in the ER, and a 40-year-old man is presented to you with the suspicion of intoxication. You walk up to examine the patient, and you see he is breathing very rapidly with the normal saturation at room air. He is slightly hypertensive and tachycardic with the normal EKG. His consciousness is reduced, but he has a normal glucose, and his temperature is normal. Before you can go and perform your physical examination, the nurse walks up to you and hands you a piece of paper. She already performed a point-of-care test, including the ABG. So let's have a look. You see an acidemia from metabolic origin with complete respiratory compensation, or even a little overcompensation. The next question you have for me is, but what's the anion gap? Well, the anion gap is increased, 36 to be precise. So we're dealing with a high anion gap metabolic acidosis. And the anion is also given to you, namely lactate. Case closed, right? We're dealing with the lactic acidosis. Maybe he took liters of propylene glycol, which is metabolized into lactate in the liver, but no. Given the apparent absence of tissue hypoxia or shock, we figured this must be a measurement error. So we asked the nurse to repeat the test, but again, we get a lactate of above 30. So we decide to send the sample to a central laboratory. Well, and while we wait, we get a result back, and it's 9. So we have a discrepancy of 21 millimoles per liter. So we were puzzled. So let's take a look, actually, how the point-of-care test actually works. Well, the point-of-care test converts lactate into pyruvate by using the enzyme lactate oxidase. And lactate oxidase is not an enzyme that's commonly or naturally occurring in the human body. We actually borrow it from bacteria. It converts lactate in pyruvate by using oxygen, and it forms hydrogen peroxide. And it's actually the level of hydrogen peroxide that's used as an approximation for the amount of lactate in the blood. However, in the presence of a molecule which has a similar structure, glycolate, the same reaction occurs. And glycolate is converted into glyoxylate. You produce more hydrogen peroxide, and therefore you get a falsely elevated lactate level. But what do they do in the central laboratory? Well, in the central laboratory, they use a different type of enzyme, namely lactate dehydrogenase. And NAD+ is used, and it forms NADH, and the amount of NADH is used as an approximation for the lactate level in the blood. And this enzyme is very specific and does not recognize glycolate. Therefore, you get a more accurate and sensitive reading of the lactate in your sample. But where does the glycolate actually come from? Well, glycolate, or glycolic acid, my slides are a little bit messed up, is a metabolite that's formed after ethylene glycol is metabolized. And you all know ethylene glycol, it's an alcohol that's commonly used in industrial solvents and also in antifreeze products. It's used for attempted suicide, but also accidental ingestions because it has a sweet and colorless smell and taste, and so kids can take it. And ethylene glycol is converted into glycoaldehyde and then in glycolate. And it's actually the glycolate that after accumulation leads to the metabolic acidosis. Because ethylene glycol is not that toxic, and 20% gets excreted by the kidneys and 80% will get metabolized. Glycolate is then further converted into glyoxylate and oxalate. And that's actually annoying because the oxalate can bind to the calcium in the blood, form crystals or deposits, which can accumulate in the kidney, lead to an ATN and acute kidney injury. And it turned out that the family members of our patient told us that he took or drank ethylene glycol from antifreeze because he was psychotic. And you can actually look for these crystals in the urine. You can have monohydrate calcium oxalate crystals or dihydrate oxalate crystals. This is an example of the second one. And it also led to an acute kidney injury in our patients, where his creatinine levels almost reached above 900. But let's take one step back, because we still measured a lactate level of 9 millimoles per liter in our patient. Is there another way we can explain it aside from the metabolic acidosis? Yes, we conjectured that pyruvate is shunted to lactate in the Cori cycle to replenish the amount of NAD+ to keep this cycle or process ongoing. So what's another trick you can use to look for osmotically active substances in the blood? Well, the osmogap. I'm sure you're all familiar with it. You can measure it, and then you can calculate it. And if you have a difference, then you know there are osmotically active substances in the blood. But we weren't impressed by an osmogap of 30 millimoles per kilograms. So how can we explain this? Well, right after you ingest ethylene glycol, it will act like an osmotically active substance, and it will contribute to the osmogap. So you will find a very high osmogap, and it's not toxic. And while it gets metabolized and you start accumulating glycolate, you'll see that the osmogap will decrease and the anion gap will increase because of the metabolic acidosis that it causes. And we can learn two lessons from this. One, you can have a normal anion gap and a normal osmogap in the ethylene glycol intoxication. And two, you can use the anion gap and osmogap to get an indication of the timing and severity of the intoxication. But were we right? Were we correct? Was his family right because our patient was in the ICU? Yes, because after a few hours we got our ethylene glycol level, which was 550 milligrams per liter. And levels above 500 are associated with a high risk of mortality. And you can actually convert it, and that's what we did. And then you find a level of 9 millimoles per liter, which accounts for the majority of our osmogap. So how do we treat an ethylene glycol intoxication? I'm sure you all know how to do this, but let's go over it. You can prevent the accumulation of the toxic metabolite by blocking alkyl dehydrogenase. You can administer fomepizole, which is a competitive antagonist with a higher affinity for ADH. Or you can give ethanol, which is a competitive substrate and also has a higher affinity. And therefore, your kidneys can excrete the ethylene glycol, you prevent the metabolic acidosis. And also, if someone has co-ingested ethanol in case of an ethylene glycol intoxication, that person is basically protecting themselves from the metabolization of ethylene glycol. Furthermore, you can, further down the pathway, you can administer cofactors, vitamin B1 or vitamin B6, which will stimulate the formation of less toxic substances, and you'll prevent the calcium oxalate crystals from forming. And last but not least, when you have an indication, so severe metabolic acidosis with a high anion gap, or the patient is in the ICU or has levels above 500 of ethylene glycol levels, then you can perform dialysis, hemodialysis. And our patient was treated with everything, and of course supportive care in the ICU. He got 1 round of hemodialysis. After his neurological state significantly improved, he was discharged from the ICU into the psychiatric ward. And after a few days, he was sent home, and his kidney function normalized when he visited the outpatient clinic. So the diagnostic trick, a lactate gap is very specific for an ethylene glycol intoxication, and it's a very early marker glycol intoxication. It's very easily performed if you have a point of care test and you can await the results from your central laboratory, and you can start prompt treatment and improve outcomes. And this is something that is not written down in any guidelines, as far as I know, especially not in the Dutch toxicology guidelines or treatment guidelines for ethylene glycol intoxication. So to give a quick overview of the diagnostic tricks in ethylene glycol intoxication, with respect to the clinical presentation, well, if a child who has accidentally taken ethylene glycol, they will say it was a sweet and colorless substance. Its clinical presentation will resemble an ethanol intoxication without the odor, so CNS, depression, cardiovascular problems, and then kidney failure. But regarding to diagnostic testing, well, in my honest opinion, I think the lactate gap is the earliest and best specific test for an ethylene glycol intoxication. There's no other alcohol that will cause a lactate gap. I read that in veterinary medicine, they use enzymatic assays, which are pretty cheap. However, they have a very low specificity, leading to false positives. And I'm very curious if anyone in this room has heard of such tests or is using them clinically. Late tests are your serum ethylene glycol levels, but not every hospital can test for this. But it's the gold standard. You can look for calcium oxalate crystals in the urine, but they're not very specific, and it takes a long time. And they can cause a secondary hypocalcemia because they bind to the calcium in the blood. However, our patient did not have that. And last but not least, you can use the osmo gap and the anion gap to get for the timing and severity of your intoxication. That was my presentation. Thank you all for your time.
Thank you for this brilliant presentation. I mean, I remember I saw this patient at the ED and remember struggling with the lactate level, which was disproportionately high, and eventually got the diagnosis. Siham, very well done. Have you got any questions? Yes, please.
I have one question, actually. I have one question. How easy, this material available at the household? Is it accessible for, people at home? Is it used easily?
I don't think so, because it's used in industrial solvents and antifreeze. But maybe if a kid is playing in the garden and has access to the shed and then maybe accidentally drinks it.
But antifreeze is available. Antifreeze is pretty easily available.
Yeah, you mean in stores? Yes, but not at home.
Okay, so it's not available at home. Okay.
The other thing is the methanol has also something like this. When you have methanol intoxication, yes, especially when they have illicit alcohol. So sometimes we also see methanol intoxications like this presenting.
Yes.
But this was a really, really interesting case, and the patient made it home, so which made it more interesting.
So since you mentioned methanol, so homemade alcohol Is it a risk for such a patient? So we need to take in consideration lactic acid in these patients.
I don't hear you properly. Can you please?
In methanol, do you need to do you think also they have the lactate gap in methanol?
No, they don't.
No, so-
Because it's the glycolate that has a chemical, the molecule glycolate is very similar to lactate. That's why the enzyme recognizes glycolate as lactate. However, in methanol, you don't have a similar chemical structure. That's why it's very specific, very easy test to perform.
So we see, I know in Poland they have lots of methanol intoxications. I know in Sri Lanka, India, they have lots of methanol intoxications, but ethylene glycol is specific, yeah. Please.
Thank you very much. It was very nice. My question is about, you said homemade, right? In Turkey we say fake alcohol. It is done in home. It is directly, it has a very high relationship with the economy, because in Turkey, when the amount of the alcohol became very expensive, the people, they started to make alcohol in home. So we have very high mortality of this patient. I just am wondering, do you have such problem in your country about the fake alcohol?
I don't think that a lot of people in the Netherlands make their own alcohol.
No.
No, it's very easily available in the Netherlands and pretty cheap. You can buy beer for very little money.
But it's cultural, you know, it's like during long time ago when they didn't have ways to clear water, they gave children beer. Because beer is much more purified than water, you know. So in the Western culture, alcohol is available everywhere. And it's amazing how much alcohol is available. So you're right, we don't make any illicit, you don't have to.
You know, alcohol is available in Qatar, but available to a limited extent in a certain area and certain, permit for different people. And we used to have actually people, especially the people who work in the industrial area, coming with not homemade, but they drink actually a sort of eau de cologne, so like a perfume, cheap type. And they usually come with a really severe toxicity, with a liver failure. But unfortunately, that's what happened for them. And now it's homemade, maybe much easier.
Blindness, huh? We had couple of Polish guys with blindness also in the Netherlands. They were making their own alcohol because they wanted it more cheaper, and that was really bad what happened.
Our definition is very nice, fake alcohol.
Thank you. You brought me back to biochemical, studies when, in second medical year, which is very important that we go to the basic, and really that's an eye opener for me. Thank you very much.
Thank you very much.
Thank you. Thank you.
Yeah, please.
So I hope I pronounced the name right. Anarov, is it Dr. Anarov? Sorry, I have. But the topics is reoxygenation, ischemic reperfusion injury, and acute carbon monoxide injury. Thank you.
Much, Mr. Chairman.
Professor, thank you.
I'm Dr. Hikmat Anvarov. I'm from Uzbekistan. I'm a deputy director for the National Republicans Research Center for Emergency Medicine, and also affiliated with the Central Asian University in the position of the associate professor. I have nothing to declare on this presentation, and actually this topic has been started in last November in the recent VASEM conference in Rome. I've been highlighted our very fresh research related with acute CO poisoning and our findings. And here I would like just to highlight what we have achieved for that moment. So, Carbon monoxide results from the incomplete combustion of the carbon-containing substances, and it's colorless, odorless, and tasteless gas. Exposure of the most commonly from the car exhaust, faulty heaters, fires, industrial accidents, and charcoal burning, suicide. Moderate or serious poisoning can cause for high oxygen demand organs injuries and dysfunction, among which the brain and cardiac effects dominate with acute clinical features. So here's the mechanism on the slide. CO products toxicity by binding the hemoglobin, thereby reducing the oxygen carrying capacity, and by binding to the myoglobin, which may impair cardiac output and result in cerebral ischemia. Severe CO poisoning result in coma or encephalopathy, but milder intoxication may occur with non-specific symptoms suggestive of the hysteria, hyperventilation, psychosis, or even viral syndrome. Survivors of severe CO poisoning may have permanent neurological and neuropsychiatrical consequences. So, traditional treatment in case of the mild carbon monoxide poisoning, it's enough just to bring the patient to the fresh air. But in case of the more severe poisoning, the patient needs to be given the concentrated oxygen with an oxygen mask, either artificial ventilator or even in the hyperbaric chamber. So, immediate reperfusion is often a necessary life-saving intervention for patients, given that ischemia and the hypoxic injury arise via insufficient oxygen delivery to tissues, which may think that restoration of adequate oxygen supply would remedy for the problem. But in IRE, reperfusion paradoxically leads to the persistent and sometimes increasing tissue damage, as noted macroscopically by preserved tissue and architect and relative the cellular in the ischemic tissues, while tissue visualized following the IRE reveals necrosis with neutrophil infiltration. Therefore, based on the data of the damaging role of the oxygen in case of CO poisoning, taking into account the obvious clinical signs of acute coronary syndrome, cerebral edema, and lungs that develop on the patient, we can confidently assume that during CO intoxication, oxygen therapy actually leads to the development of the total reperfusion syndrome. That is a paradoxical and dead-end situation arises when the doctor is obliged to conduct the antidote therapy as oxygen, but in the same time condemns the patient to the development of the fatal complications. Also, I've mentioned the IRE. IRE is an ischemic reperfusion injury, and it's quite well-known, recognized phenomenon, potentially occurring following the nearly any ischemic insult to the tissue. Upon restoring blood flow, a secondary reperfusion injury can further damage the tissue. It can occur with any injury that involves the interruption of the vascular flow. So we quite commonly have seen it when in the reperfusion syndrome in the acute cardiac arrest or after, for example, the liver transplantation. So, the ischemic state induces anaerobic metabolism leading in a lower level of the ATF production and failure of ion exchanging channels. Failure of the ion exchanging channels leads to the cell swelling and impaired enzymatic activity in the cytoplasm. As we can see it here, the ischemic reperfusion injury is very similar what we see in the brain cells in the acute carbon monoxide poisoning and the oxygenation afterwards. The same, we can see the similarities in the lung tissues too. So in case of the CO intoxication, reperfusion syndrome is also possible. And And we have to prove these hypotheses, and it was the last year for us, the main task in starting that research. So the changes in the clinical picture after the reoxygenation in severe carbon monoxide poisoning, we have to confirm, are they persist? And I think yes. So can we say that based on the molecular mechanism of the development that in carbon monoxide intoxication, oxygen therapy actually leads to the development of the total reperfusion syndrome? Here are the findings of our own hospital, one of the biggest in my country. We have analyzed over 210 patients after oxygenation due to severe CO poisoning, and you can see the results here. Also, the serious changes in intensive care can be done after this research. So there are two ways to prevent this reperfusion syndrome: xanthine oxidase inhibitors and NADPH oxidase inhibitors. So if we can anticipate these deadly complications of the reoxygenation, I think we can start immediately this medication and prevent the patient from this complication. Yes, again. And so in our research, we have divided on two parts. Part one is the experimental one and was dedicated to study the effect of the toxic doses of the carbon monoxide for the bioenergetic status of the cell. Also, we have to study the effect of the reoxygenation on the cell and study the role of the various sources of the oxidative stress. So it's a mitochondria, NADPH oxidase, xanthine oxidase, etc. And also to determine, using the several methods, the potential modulators of the oxidative stress system among the substances isolated from the local Uzbekistani plants. And here are the modeling, what we are doing now. So we have isolated and cultivated the primary cells from the organ in mice and saw these kind of changes in neurons and astrocytes as well as in the cardiomyocytes. Also, the second part of the research is a clinical task, consists of the studying the cerebral reperfusion syndrome in patients with a severe CO poisoning and reperfusion consequences. Also studying the myocardial reperfusion in all target organs, which are the brain, heart, lungs, and kidneys. And to conduct the comprehensive metabolomic analysis in carbon monoxide poisoning. Just to shortly wrap up these highlights, let's conclude the two main theses. The study of the phenomenon of the reoxygenation is in acute carbon monoxide poisoning, I think, is a new and quite promising direction of the fundamental science and clinical toxicology. And the confirmation of the toxic effects of oxygen and the development of the measures of the counteract these effects will significantly reduce the number of the complications of severe carbon monoxide poisoning, such as cerebral edema, pulmonary edema, and acute coronary syndrome. Thank you.
Thank you very much. Very interesting. Any questions? I was just wondering, if you give oxygen to a patient with myocardial infarction, we know that if you give too much oxygen, there's a high chance of dying. That's because of peroxynitrate, which is being formed with oxygen and NTG, nitrous. Is carbon monoxide poisoning different now? Is oxygen dangerous for every sick patient, too much oxygen?
I hope to be able to answer fully for your question within 2 years, I think, when the research will be done properly. But staying here, yes, I think we can see, as I said, the same almost the same syndrome what we have in the acute cardiac arrest and the rechannel. When we open the coronary artery and we see this reperfusion, we see this fibrillation, the myocardial fibrillation. I think it's the same mechanism.
Same mechanism, yeah, exactly. So you study the mechanism of hyperoxia,
Yeah.
of course. Yeah.
Hope so.
Thank you very much. It really changed my mind for the treatment of carbon monoxide intoxication. I have some experience about carbon monoxide because I have been in the cities in Gaziantep. This is the city that carbon monoxide intoxication happened the highest in the world. Just a simple example. We had over 800 cases just in one night because it happened due to the stove heating. You explain about the reoxygenation problem. So do we have a threshold of giving the oxygen to these patients? There should be. Because the thing that we know, the best way, the best treatment is giving the oxygen. That's okay. So do we have any threshold for giving the oxygen to such patients?
Yes. Again, you know, and I said it, for the light poisoning, it's just enough to bring the patient to the fresh air. When we have to start the oxygenation itself, we have to see the myoglobin. We have to see carboxymyoglobin in the urine and in the blood, and we have to see the saturation.
Saturation. As we know, the saturation is not a real examination symptom for us because when you check the oxygenation, I mean with pulse, the oxygen saturation is okay. It looks like 93. That's okay. But when you look at the level of the oxygen in cell, you see it is very low. So that's why this patient should need to be given the oxygen. It is not a true way to watch the patient with saturation, with pulse, in carbon monoxide intoxication. And the other thing, for example, your patient has, myocardial ischemia. The troponin level is high. We have abnormality in ECG. So this is an indication to give the high saturation of the oxygen to these patients.
Yes, and that is the point, that the treatment became the tool of the killing, actually. And here we have to see the blood gases too. When we see the metabolic acidosis, we definitely have to intubate the patient and give the oxygen. In another hand, yes, we have to prevent this reoxygenation. What we do think in the end of this research, we will be able giving this NADH plus inhibitors.
I mean, you mean there's a discrepancy in CO2 poisoning with the measured saturation and the calculated saturation. Most of the labs use calculated saturation on the PO2 level. So when you have somebody with carbon monoxide poisoning at the emergency department, you've got to call the lab and ask them to measure it directly. That's what I think you mean. So that's the difference. And at the ED, we always look at the PO2, and if you don't tell the lab, they'll just derive saturation from PO2. That's the discrepancy.
Thank you.
A question. As you know, I am not actually in toxicology, but this is very interesting. In vascular, when we reperfuse a ischemic limb, we usually, even if there is no compartment syndrome, if we suspect that the ischemia time is long, we do actually fasciotomy. That to decrease the chance of actually swelling and also the impact of the compartment due to reperfusion. So in this case, as you say, treatment sometime can actually inflict the damage. We put them in hyperbaric to treat them, but on the other hand, it will cause, the oxygenation, reperfusion elements. If you give, with this treatment, the inhibitors, do you think that will decrease the chance for the ischemic events that happen from the hyperoxygenation as reperfusion? Or that's the answer after 2 years?
Yes, maybe, to be more precise.
But is there a chance that you do a prospective study in the lab because you're already doing this?
Yes, I think maybe in 6 months we'll be able to highlight the two.
Excellent.
No.
Thank you. That's actually amazing job, outstanding. If you combine the basic lab plus the clinical, we look forward for the result because you're going to implement imaging plus also functional outcome for these patients. That would be great. Thank you.
Thank you.
Thank you very much. Very interesting. Thank you. Next presentation is by Dr. Mohammed Barani. Yes. Yeah, I saw. He's giving 2 presentations. First is on metal phosphate poisoning. So we'll do that first. And then we go to statistics on aluminum phosphate poisoning. And that's also really interesting. So he's going to give us 2 interesting topics. We'll do the first one, take questions, and go to the second one.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. Distinguished my dears, ladies and gentlemen, it's my honor today to be with you in this esteemed gathering to present the results of scientific study and the medical intervention that has had a profound impact on saving the life of hundreds of individuals. These individuals no longer bear the weight of life's challenges and hardships. This intervention has granted many a renewed hope for life. Unfortunately, when wars and disaster prevail, when homelessness spread and safety losses, despair can easily take root in people's hearts. The resilience human spirit may break, and some individuals may begin to wish for death as a means of escaping this reality, yet find no way out. This study is the aluminum phosphide poisoning in disaster-stricken area can early hemodialysis improve outcomes. Yes. We know the mortality rate from aluminum phosphides poisoning is alarming high, approaching 100% in all confirmed cases of real poisoning. I want to present the success story. On July 22, 2022, a 32-year-old male patient was brought to our emergency department after ingestion to gas bill. We immediately implemented the standard treatment protocol, which all over the world is did. However, we decided to take an additional step with performed hemodialysis for patient. Aluminum phosphide is a pesticide for grain storage. It's used as a residual or hemodial agent. It causes occupational hazard to grain storehouse workers. no antidote for poisoning of aluminum phosphides, and no biomarker is currently available. Early diagnosis by biomarker development can provide early support management or support treatment. This, however, this aluminum phosphides gas spill or rice spill in India, in Egypt, in Syria, in Yemen, it's inexpensive and evaporate upon exposure to weight and to air. And if people ingestion this bile, it's happen reaction with stomach HCl and evaporate, and the outcome of this, it's BH3 phosphine gas. It's very poisoning gas. That's gas bill. It's inexpensive, and in all market it's available. And if that reaction with HCl and stomach liquid, that's its phosphine, at phosphine gas, its damage and absorption. Why people get this pill? The reason is suicide attempt, and maybe some people taken by mistake or unintentional. What the mechanism of toxicity of aluminum phosphide? When people ingestion or inhalation this bile, it's happen reaction with the humidity of hydrochloride in stomach, and then release of phosphine gas absorption, and then happen damage in the level of mitochondria inside cell. That's the expiration prefer transfer from aerobic to anaerobic respiration inside mitochondria. And this outcome of this happens lactate, which is do the necrosis in myocard, necrosis in cells in lungs, and multi-organ dysfunctions. What are the symptoms? Symptoms, it's vomiting, nausea, and abdominal pain, epigastric pain, asphyxia, and then there is some symptomatic symptoms. This protocol, which is for treatment, for approach, ABCD, and then CV line, and take the blood for analysis for blood gas, and renal functions, liver functions, INR, BT, and then yes, and then we bicarbonate, Yes, and we support patient with fluid, IV fluid, and we control his lactate level in blood. What we doing for patient in the story? We decide to take an additional step. We performed hemodialysis, early hemodialysis for patient. And we development modified AMA protocol for management of aluminum phosphide poisoning. As we see in this protocol, this gastric lavage, magnesium sulfate compensation, hydrocortisone, and bicarbonate compensation, potassium also, ringer, that's fluid resuscitation, and early hemodialysis and continuous hemodialysis whenever possible. We monitoring vital signs, troponin, D-dimer, ABG, volumetric status using central venous pressure, inferior vena cava superior pressure, ECG periodically, and periodically ABG test for gases and electrolytes. This study, it's on 16 people who poisoning aluminum phosphide. That's it. All take the toxic dose of aluminum phosphide by ingestion of rice meal, which is inexpensive and available. And 15 poison cases were suicidal attempts. 3 patients died. Most of these patients is female. 69% is female, and the average of old 18 years. 4 patients from these patients had intubated. 10 patients had of alternative consequences. 11 patients need vasopressor support requirement, and all patients had creatinine 1.2 milligram or less. All this documented patient time between taking, that is arrived to emergency department from 1 to 5 hours. If we review the mean age, 18, the most of them female, and the most 10, 91% need vasopressor medication, intubated 28 from them, and the pH, mean pH 10.23. Lactic acid was very high in all patients, almostly. Hours between ED and submitted in ED and intoxication, that's 1 to 10 hours, 3 hours in median. What what hemodialysis, its indicators for hemodialysis: machine, duration, and blood flow, dialysis fluid, bicarbonate bath, potassium bath, high potassium solution also, dialysis fluid. We found the phosphate aluminum, we find phosphine gas in liquid of hemodialysis by reaction with silver nitrate. We did the reaction in laboratory in northwest Syria, and the silver nitrate changed the color to dark, and we did like witness experiment. We heating the liquid of hemodialysis for renal failure patient, and not change color. That's we prove that the phosphine has been found hemodialysis fluid. Conclusion: metal phosphide poisoning is common in the affected area, northern Syria, other countries. Most cases and the all cases almostly are suicidal attempt and occur in young women. This woman must more than male. Mortality rate close to 100% in real poisoning cases. No laboratory markers, biomarkers for distinguish of toxication with aluminum phosphide. No antidote for phosphine poisoning. The recommended treatment is supportive care only. In northwest Syria, in a resource-limited and unstable region, clinical protocol was developed by implemented early hemodialysis for patients' critical condition after ingestion of phosphide metal. Early dialysis intervention improve outcomes all over the world if we early apply the hemodialysis for patients. In 2023, we have this statistic: 39 patients, 34 survived, only 5 deaths. In 2024, we have 65% survived people and 35 lethal prognosis. Most of patients which had poisoning is female, 75%, and most of the population were from IDBS, 92, and 58, it's men, 53% married. This my colleagues, which is contribute in this study and doing, and this of the references for study. All these patients after survived submitted for psychological support. It's okay, thank you very much.
Thank you very much. Interesting presentation. Are there any questions? Please.
Dr. Hamad, thank you. I do have one question. Hemodialysis in these patients, based on the literature, is there actually a role for hemodialysis based on your study. There is no solid evidence that hemodialysis made a big difference. You implemented hemodialysis in these patients early. Even you have 10% or 10 patients out of the 16 were on shock requiring support. So do you think that the hemodialysis played a role, or just the general support played a better role than this?
I think that the hemodialysis that's play a role in surviving rate. That's because it's the target from hemodialysis. It's to reducing the effect of lactate and the effect of metabolic acidosis in cells, which affected on myocard cell and other cells, and also it's due to multi-organ failure, and also that's to reducing the effect of poisoning phosphine gas, because we find phosphine gas in hemodialysis liquid. We prove that phosphine gas by reaction with nitrate, silver nitrate, dilating this and gas sulfuric.
Yeah, but that's not very accurate. That reaction can be even from something else. So without accurate measurement, I will not take it as a solid evidence.
We put that's like criteria for dialysis.
Yes, okay.
For example, that's if
Dr. Mohammed, shall we go for the next presentation, because we have only 19 minutes left.
this presentation only video in the end of presentation, because this training MH gap for people, for mid people, for doctors and for med personnel on MH gap humanitarian intervention guide to study case, psychological study case for suicidal attempts of these people. That's its follow-up of these people. Yes, we can see the
Yes, thank you.
this. These questions, paramedic or doctors or psychological specialist to patient, that's as a person recently attempted suicide, self-harm, poisoning, sign requirements, what the signs of urgent medical treatment, yes, and questions to explore ideas and plans for suicidal attempts, yes, these questions, and then role play, that's it's including in training, role play for explore the suicidal attempts. This also has person attempt suicide or self recently. All these questions and current, and if that's after medical therapy, that's submitted psychological support by specialists.
Thanks. You got 14 minutes for the next presentation, so maybe you should Oh, is this the presentation?
Video.
You'll be talking about organ metal phosphate poisoning, but no, this is the presentation?
Yes,
Mohammed,
yes.
you have another
It's all
presentation?
presentation because it's for specialists for
I see.
Yes.
Okay.
Okay.
image gap training videos.
متخافي عملنا بس وحده ونخلص ان شاء الله بكون رجعتي عظيم عاوز صفتي كم دواء للجرح ولا بتجري مرتها نادي بدها تحكي معي موافقه؟ اوكي سلامتك
بالوقت اللي الدكتور جميل عم يكتب لي وصفة الدواء كنت عم بتساءل ممكن تخبريني شو صار؟
ما بعرف بالضبط شو صار. كنت كتير معصبة من بعد المشكلة مع خطيبي. حسيت كل العالم عم بينهار. وجعني الموضوع كتير وكان بدي موت. فرحت على الحمام ومسكت شفرة.
شو صار؟
حسيت بدوخة. رحت مددت على تختي وفات خيي صغير صار يصرخ لأهلي.
أكيد كنت كتير زعلانة. وهلأ بعدك حاسة بنفس الشعور؟
ما بعرف. بدي لأنه يرجع.
خطيبك؟ وقبل هيدا الخلاف كيف كانت علاقتك مع خطيبك؟
كنت كتير راضية، كان كل شي بأحسن حال. كنا نختلف بس خلافات عادية.
ندى ممكن اسألك كم سؤال بعد؟ هيدي أسئلة روتينية بنسألها للكل. في أدوية
Another video. I think that the aluminum phosphide and zinc phosphide poisoning that's also spread in other countries like India. I don't know that's the protocol in India to treatment and treatment these cases. It's like Syria or that's when hemolysis
خليكم قريبين. أنا رح أرجع بسرعة. هيدا الدكتور جميل رح يفحص إيدها لندى. ندى رح كون مع أهلك برا بالغرفة الثانية.
مرحبا ندى في يفحص لك ايديك؟ لا ما تخافي رح افحصها على مهلي. الجرح عميق شوي بضطر اعمل كم خطوه.
واضح انه بالكم كثير مشغول عن ندى. ممكن تخبروني شو صار معها؟
يعمل حدا على خطيبها. اجا ليزورنا اليوم بعد الظهر وبعدين تخانقوا. هو لما فل معصب كثير من عنا. شفت ابني صغير هيك تصوبه وعم يصرخ يا ماما يا ماما ندى عم تنزف.
ركض انا على اوضه النوم لقيتها بالقوحه على التخت وايدها عم تنزف، جبت شقفه قماش خزقتها ربطت لها اياها بسرعه وحملتها دغري وركض لعندكم على المركز لهون.
اكيد هيدا الشيء كان كثير مخيف لكم.
حتصير منيحه طمنيني.
الدكتور عم يهتم بايدها. عرفتوا على شو ندى وخطيبها كانوا عم يختلفوا؟
لا هن بالعاده بيختلفوا، بس ما بيصير هالشي بيناتهم لهالدرجه. صار لهم سنتين خاطبين، بدي يتجوزوا الشهر الجاي.
لاحظتوا شيء مش طبيعي بندى بالفترة الأخيرة؟
بالعكس اليوم الصبح كنا عم نقول انه بدنا نروح نفتش على فستان العرس، وكنت كثير محمسه ما بعرف شو صار.
ندى شي مرة أذيت حالها أو هددت إنه بدها تأذي حالها؟
لحد علمي لا.
حسب ما عم بفهم إنه قبل الخلاف الأخير ما لاحظتوا أي شيء بندى خليكم تقلقوا؟
ابدا ما حصل.
ابدا.
رح روح إلقي نظرة على ندى، ولما أرجع أنا وياها ضروري تبقوا هادين وتبينوا لها إنكم بتحبوها. بعرف إنكم خايفين ويمكن معصبين، بس تأنيبها هلا ما بفيد. لما تروحوا على البيت حاولوا أبدا ما تتركوها لحالها، وخبوا أي شيء ممكن تأذي حالها فيه.
مثل شو يعني؟
كل الأدوات الحادة، الأسلحة، السكاكين، الحبال، مبيدات الحشرات، ما تخلوها تطلع على السطح. أي شيء ممكن يخطر على بالكم.
بتخافي؟ تعالي أنا بس وحدة ونخلص. إن شاء الله بكون رجعتي. عظيم. رح أوصف لي كم دواء للجرح. هلا بتجي المرضى هنادي بدها تحكي معك.
موافقة؟
اوكي؟ سلامتك.
ندى، بالوقت اللي الدكتور جميل عم يكتب لك وصفة الدواء كنت عم بتساءل، ممكن تخبريني شو صار؟
ما بعرف بالضبط شو صار. كنت كتير معصبة من بعد المشكل مع خطيبي. حسيت كل العالم عم بينهار. وجعني الموضوع كتير وكان بدي موت. فرحت على الحمام ومسكت شفرة.
وبعدين شو صار؟
حسيت بدوخة. رحت مددت على تختي وفات خيي صغير صار يصرخ لأهلي.
أكيد كنت كتير زعلانة، وهلأ بعدك حاسة بنفس الشعور؟
ما بعرف، بدي لأنه يرجع.
خطيبك؟ وقبل هيدا الخلاف كيف كانت علاقتك مع خطيبك؟
كنت كتير راضية، كان كل شي بأحسن حال. كنا نختلف بس خلافات عادية.
فهمت. ندى، ممكن أسألك كم سؤال بعد؟ هيدي أسئلة روتينية بنسألها للكل. في أدوية بتاخديها؟
لا.
تشربي كحول؟
لا.
تتناولي مواد تانية أو مخدرات؟
لا.
في فكرة معينة بتشغلك غير الخلاف مع خطيبك؟
لا.
كنت تستمتع بالاشياء قبل ما يصير الخلاف؟
ايه، كنت اطلع مع خطيبي ورفقاتنا.
قبل الخلاف فقدت اهتمامك بالنشاطات اللي كنت تستمتع فيها عادة؟
لا.
حسيتي انه نشاطك تراجع؟
لا، كنت منيحة.
ندى، بتعاني من اي وجع مزمن؟
لا.
غير الخلاف مع خطيبك في شيء ممكن يكون سبب لك هالحزن؟
لا.
واجهتي صعوبة من قبل ما خلتك تقومي بنشاطاتك اليومية؟ خبريني عن علاقاتك الاجتماعية.
عندي كتير رفقة وبحب زور القرايب.
هيدي أول مرة بتأذي حالك؟
ما في أتخيل حياتي بلا خطيبة.
وكيف حاسة حالك هلأ؟
كتير خايفة وزعلانة وبدي يرجع.
حاسة إنه بدك تعيديها؟
بس بدي إياه يرجع.
شو ممكن يوقفك من إنه تأذي حالك مرة تانية؟
يشغل بال أهلي.
إذا حسيتي إنه بدك تأذي حالك مرة تانية، شو الأشياء اللي ممكن تعمليها؟ لما كنت تحسي بحزن أو تعاسة، شو اللي كان يساعدك؟
الحكي. بحب كثير أحكي.
Dr. Mohammed, we have only 5 minutes more. Can we stop the video and ask some questions, get some questions?
فهمت. في
It's an interesting video, so shall we ask the audience whether they have any questions, because it's a heavy topic? Are there any questions?
I have a question actually. In this video, I think what you presented in the first one and the second one is how we as caregivers take information of the individuals. And I think this is a very, very strong element. I don't know, in my hospital, we actually employed a psychologist with the trauma team to deal with these patients, because I think this requires a special task in order to address these issues. But do you have actually a specialized individual or a specialized nurse who take these histories and physical examination, or just history mainly?
Yes, I see that some cases, and I tried to treat some cases in hospital in Amanos, Afrin hospital. That's but it cases for a woman that's 18 year old, and we refer immediately after lavage and civiline and fluid resuscitation to renal central for hemodialysis. Yes.
سؤالي دكتور محمد، المرضى اللي يجون بمحاولة اغتيال يعني اوفر دوز، هل انت يوجد عندك نرسات متخصصين لرعايتهم او اخذ الاسئله والاجوبه منهم؟
Psychological.
Psychological, or somebody who is specialized?
Yes.
Are they gender specific? Like you have male for?
Yes, of course.
Okay, excellent.
Yes, of course. And I have the statistics and the table for and with code for specialties.
Thank you. If there are no other questions, we had a very interesting session on 4 types of intoxications, from ethylene glycol, about hyperoxygenation injuries, about epidemiological poisoning, and also aluminum phosphate poisoning. I found it an interesting section. Thank you very much for all the speakers. And Dr. Altani, thank you for sharing also. Thank you.
Thank you.
Good evening.
Okay, the last section of the day. So we have 3 presentations. The first one is Dr. Ruth PC1, and the topic is when the appendix doesn't play by the rules, navigating atypical presentations. Okay, you can start.
Good evening, everyone. I would like to thank WASM and DPAT for giving me the opportunity to talk to you. So I would like to speak about the topic, atypical appendicitis. As you know, appendicitis is a common surgical emergency, but even seasoned clinicians can go wrong when it comes in as atypical appendicitis. So in this presentation, I would like to throw 3 clinical scenarios, real life scenarios, which I encountered and had some issues. So first, as we all know, Alvarado score is one of the important stratification tool we use while managing appendicitis. Appendicitis is common, but it's not always classic. Atypical presentation may delay diagnosis and increase morbidity. Regarding the Alvarado score, there are 8 components with a maximum of 10 points. It is a stratification tool. So if it is more than or equal to 7, we will say it is more of suggestive of appendicitis, and if it is less than 4, it is unlikely to be appendicitis. And for 5 to 6, we will take it as indeterminate. So common rules we use while, as I am an emergency physician, so we use rules, scores, and something easy to stratify all these things. So Alvarado score is a triage tool we use for initial risk stratification. A low score makes appendicitis unlikely. As I said, less than or equal to 4 means it is a low score, and it is highly unlikely to be appendicitis, and high score means highly suggestive of appendicitis, and it may obviate the need for CT. CT has greater diagnostic accuracy than the Alvarado score, with sensitivity and specificity of 90 to 97%, and it is commonly indicated in intermediate score cases. It is a rule. Whether it helped me, we will find. So patient with very high score, we can send to surgery directly. So we use a combined approach. Alvarado score provides a quick, non-invasive estimate of appendicitis risk, and CT scans findings confirm the diagnosis with high accuracy when the clinical probability is uncertain. So direct to the first case. So this is a case of 12-year-old male child with left iliac fossa pain. So left iliac fossa pain, anorexia, vomiting, and loose stools were the presenting complaints. There were similar history, about 4 to 5 similar episodes in the last 2 years, and all ends up with a normal ultrasound and always manages with some analgesics for 3 to 4 days, and at times antibiotics were also prescribed by pediatricians. So in our emergency department, while examination, the child was having a tenderness in the left iliac fossa rather than more than right iliac fossa. And these were the vitals, which included a pulse rate of 95, but the child was afebrile. There was a mild leukocytosis of 10,040 without a neutrophil predominance. USG was normal. Alvarado score, I calculated, it was just 3. So our differential diagnosis, most common, mesenteric adenitis, some gastroenteritis, colitis, urinary tract infection. Being a male child, we consider testicular torsion and epididymitis, and least appendicitis also. So it was a recurrent case, and 4 to 5 episodes were there, similar episodes in the last 2 years. We went for a CT. So CT, we got 8 mm appendix with features suggestive of appendicitis. Can you play the video? Yeah. So that's a dilated appendix. And our surgical gastro team involved, and lap appendicectomy was done. Next. Yeah. Next. Okay. This is the next case. This was a 38-year-old female, came with complaints of upper abdominal pain for past 3 days. She was managed with analgesics from nearby hospital where she was staying, and there was transient relief with IV analgesics. She came to our department with lower abdominal pain later. So initially it was upper abdominal pain. When she came to our department, she was having lower abdominal pain, dysuria, anorexia, and vomiting. One of the complaint where I strike was patient complained of pain which was radiating her rectal region during every colic. I don't know its relevance, but it struck me. Past history of hypothyroidism was there. LSCS was there in the recent past 4 years, and intrauterine device was also there. On examination, there was tenderness in the right iliac fossa more than the left iliac fossa. Rebound tenderness was there, guarding was there in the lower abdomen. This was the investigation. There was a leukocytosis with neutrophil predominance. ESR was elevated. Urine routine showed 20 to 25 pulses, and we did an ultrasound, and features were most suggestive of pelvic inflammatory disease with mild fluid in pouch of Douglas and mild form of PCOD and fatty liver. But clinical examination and guarding rigidity doesn't fit with PID. We actually didn't consider appendicitis initially. We did a CT. Actually, we did a CT. CT abdomen was done, which showed acute appendicitis with contained perforation, and also features was there suggestive of focal peritonitis, and medial arcuate ligament syndrome was also there. So the Alvarado score we used, actually it was a retrospective calculation. After the CT, we calculated the Alvarado score, but it is there. We got 8. So CT unravels overlapping pathologies, and analgesics may mask signs. CT. This is a picture of CCT we did. We went for a lap appendicectomy also. Yeah. So these 2 cases, it was appendicitis. So third one is a mimicker. So this is a patient, it's a 52-year-old male, came with complaints of right iliac fossa pain since 3 days, vomiting, and fever. So we thought it is probably appendicitis. So tenderness was there in the right iliac fossa with rebound tenderness also. There was a neutrophilic leukocytosis with Alvarado score was 8, but the ultrasound was normal. High chance. Initial diagnosis was appendicitis. Second one was Meckel's diverticulitis, ureteric colic with some obstetric complications. CCT showed diverticulum arising from distal ileum with wall thickening and surrounding fat stranding. Possibility of Michael's diverticulitis was there. CCT. So our surgical gastro team did a segmental small bowel resection and anastomosis for this patient. So these are some references which are relevant to our cases. In Lancet 2015, Bango et al. Had an article which had a point that appendicitis has multiple pathophysiological pathways. So not always follow the classical presentation. So in case 1, there was non-classical or recurrent symptoms, which prompted us further imaging and consideration of alternatives. 2011, the recent BMC medicine review showed Alvarado score alone is insufficient across age group, especially in females and elderly. In case 2, female with overlying PID gynecological symptoms, we clarified it CT. SACS guidelines 2020 recommends CT for if the USG is inconclusive, if there is atypical symptoms, recurrent presentation. All 3 cases utilize CCT appropriately with after USG was normal or misleading. Regarding Meckel's diverticulitis often mimics appendicitis, so consider in right iliac fossa pain with normal appendix. So in summary, first 2 cases, it was appendicitis, but the Alvarado score didn't help us in the first case, but though the second case had high Alvarado score, it helped us in staging the diagnosis, and also underlying other pathologies were also revealed. The third case is Meckel's diverticulum. Though the Alvarado score was 8, there was a diagnostic redirection after the CT. So takeaway, maintain broad differential as always we emergency physicians do. Use CT liberally in equivocal or typical presentation. Don't ignore or persistent or recurrent pain. Classic signs are a luxury. In the very young, the very old, and women, you will need sharper eyes and a broader lens. Reassess post-analgesia if diagnosis is unclear, and always correlate history, clinical findings, lab, and imaging. Thank you.
Thank you so much for your great presentation. Of course, appendicitis still remains among the leading cause of non-traumatic surgery, so we have to consider about these kinds of atypical presentations. So it was a great presentation. We have time. Is there any question? Yes, please, Dr. Tani.
Thank you very much. Alvarado score, I think it was originally based for a patient that need to be observed or patient need to go home. The one who's clear, then that's the easy part.
Yeah.
Then the modified Alvarado added other things like ultrasound. And then the other image is CT with contrast. So in your spectrum that you present a spectrum of difficulties. A very young, an old gentleman, and in between a ladies with actually productive period of time. So these are the type of patient that Alvarado, sometime you take it with a grain of salt. You have to be very careful. My question here, and we noticed during the COVID period of time, the number of appendicitis or appendectomies decreased significantly
Did you have the same thing? Is the emergency physician start discharging all the patient with oral antibiotic, and as a surgeon we didn't operate? So why now appendicitis come back again? So that's my question.
Actually, our surgical gastro team is so proactive. They're very proactive. They will go for early interventions, actually, I think. That's why. Yeah, probably so.
Also, Dr. Sivem, I have a question. Nowadays, surgeons are forcing, of course, CT is the gold standard and useful for us, but nowadays, some of the surgeons force us to use IV plus oral contrast because they want to see all the complications, and we say them that it delays the surgery, but some of them still force us for oral contrast. What do you think about this?
So in our department, in our hospital, we use IV contrast, acute abdomen protocol for such patients. So only IV contrast we suggest.
It's enough, you say?
Yeah, yeah. Okay. They are okay with that, surgical gastro.
Yes. Okay, thank you so much. So we can pass to the next topic.
Thank you.
I invite Dr. Syed Jamal Fikri. The topic is pressure and performance, the impact of cognitive load and emotional intelligence on clinical outcomes.
Assalamu alaikum wa rahmatullahi wa barakatuh, and bismillahirrahmanirrahim. A very good afternoon to all. Welcome to my presentation. I'm an emergency physician with a special interest in disaster medicine as well as mental health education. So I do not have any conflict of interest. I come from emergency and trauma department in Hospital Selayang, Malaysia, which is a suburban hospital near Kuala Lumpur. Right. So first of all, let me acknowledge and thank the faculty of EPAT as well as WASM, as well as the Malaysian delegates spearheaded by the founding father of disaster medicine in Malaysia, Dr. Alwi. So we had a disaster workshop in Mediniyat University, actually, just earlier on this week for 2 days. It was a very fruitful and productive course that we did in the university. So let us go through a case scenario. First of all, there's a 40-year-old gentleman who came in actually to our emergency department in the resus zone with a blunt chest injury. So the emergency physician became the leader or the trauma team leader and decided to do a rapid sequence intubation for the patient. But at the same time, in this hectic environment, what happened was there's another paramedic that came over to consult the emergency physician about a 60-year-old walking lady who is obese with epigastric pain. But the pain score was only 2 out of 10 without doing an ECG in the red zone. So, however, during this hectic environment, the junior doctor that was assigned to intubate the patient fumbles the laryngoscopy process. All right, so the EP in this particular condition was very upset, and he actually screamed, "Just get out of my way and let me just do it." All right, so the EP then signs off to the paramedic and triage the 60-year-old lady to a busy yellow zone. The nurse who was in the trauma team became very anxious. So she actually gave and handed out the wrong size of ETT. So intubation became delayed. The patient unfortunately desaturated. CPR was commenced. The patient did not survive. The 60-year-old lady, on the other hand, let's come back to the second scenario, was in a busy yellow zone. So ECG was actually delayed for this patient. Patient became unresponsive and required CPR. And ECG later on revealed anterior ST elevation MI, and she died after 1 hour of resuscitation. So the questions that I would like to pose upon everyone is that, was there a burden of cognitive load in this particular patients, and also the EP managing this case? Was there a failure of communication from the teamwork? And could things have taken a different turn towards a more positive side? All right, so I would like to leave with this particular quote. The greatest weapon against stress is actually the ability to choose one thought over another. This was actually described in 1980s by William James, who is a philosopher in the USA. All right, so let's go a bit about definition. So definition of cognitive load. So what is it actually? So it is actually the total amount of mental effort that is required by our working memory at any given amount of time. All right, for emotional intelligence, on the other hand, it basically refers to the ability to understand, to regulate our own emotions as well as others towards guiding one's thinking process as well as actions. All right, so surge in emergency department. This was what happened in my department during COVID time. I'm sure it was the same worldwide. We all were fatigued, were very stressed. We had increment in surge capacity. So we didn't have enough staff, we didn't have enough space, limited supplies of the equipment as well as the systems was failing during that time. So the reality in ED, so we are all overworked. We are all emotionally exhausted and experience depersonalization up until 60%. And most emergency physicians who experience burnout have likelihood to have job dissatisfaction as well as leading to medical error. And amongst all of the specialties in the world, emergency specialty records the highest rates of burnout among their medical specialists. So in an ideal world, we would like to have beds like this. We would like to have everything not under such increase in such capacity. We want everything to be ideal. We want beds like this. We want enough monitoring. We want enough space for our patients. So that's why I described the ED bed to be $1 million bed that is wanted by all of our patients. And there is so much equipment can do. They can analyze so much information using all this high-tech technology. However, the main pivotal point is basically what lies between our ears, which is our brain. All right? Hence, I would like to call ourselves, emergency physician, as $1 billion resource that is needed to rectify all this increment in cognitive load. All right, so the daily dilemma, the pressure is of course very real. ED never sleeps, so does our cognition as physicians. Yeah. So Atkinson's model of memory has described our memory to be into 3 different categories. So we get external stimuli on a daily basis when we manage clinical case scenarios. So this will be translated into a short-term memory storage, and after that it will be reinterpreted and be kept in an unlimited storage for the long term, which is divided into explicit as well as implicit. So explicit refers to the algorithms of the knowledge that you have in your mind, while implicit refers to your muscle memory. For example, you're trying to do an IV line for the patient. So that becomes a muscle memory in the unconscious state of the long-term memory. For the working memory is something that we use on a daily basis. So it's small in storage. It is about learning and performing tasks, and it has unlimited demands depending on the cognitive load that you are being presented with. So the cognitive load theory has been described in the 1980s itself by Sweller's theory. All right, it is divided into intrinsic load, extrinsic, as well as the germane load. So intrinsic load refers to the inherent difficulty that you have in ourselves. So for example, a case that comes to your emergency department, a dizzy old lady, would be different in differentials and the management in comparison to a young chap who comes with upper respiratory tract infection with a pneumonia. What about extrinsic load? So extrinsic load refers to all the external stimuli that you get during your clinical case scenario management, right? So it may limit and distract our working memory. For example, managing a polytrauma whilst dealing with their family members who are hostile. So you have to think about the clinical management. You also have to think about the administrative issue in this patient. So it becomes an extrinsic load. Germane load refers to the processing of all of this information into decision-making schemas. So you have files in your long-term storage as a germane load. So it improves actually when you learn, you experience the clinical case scenarios, and it is translated into a long-term memory. So for example, if there's a patient that comes with shortness of breath, so you pause to think, and you interpret this information whether based on the differentials that you have. So this is actually a German load in cognitive load. So the EP's dilemma and cognitive load, so how do they interact with one another? So in an ideal scenario, we do need a little bit of pressure because pressure makes us focus. But if it's too overloaded and if it's too burdensome, it can lead to a medical error. So however, bear in mind that cognitive load evolves over time. It is improved with organizational efficiency and by the experiences that you have when managing patients. All right, our responsibilities as we move on from the junior roles up until the senior roles will also be linear to the growth that we have, and you will be able to manage the cognitive load differently as you progress into your career. So, and as you have cognitive schemas over the years, it will actually be developed into an expertise. Okay, so what about emotional intelligence? So it is divided into these 5 main pillars. So the first pillar would be self-awareness, where you recognize the signs of overload in real time. And self-regulation is when you remain composed and calm when managing a chaotic situation. What about motivation? So it gives you the drive and passion to achieve your goals. Empathy is when you are able to read patients as well as colleagues' emotional cues. And social skills is elucidated by the fact that it facilitates teamwork, especially in high-stakes decision-making scenarios. All right, so having a high IQ is what we want. Basically, this will be translated into a positive patient-doctor relationship as well as your teamwork. So you would have better bedside manners, you remain calm, you have good communication as well as compassion amongst your team members. But having a low IQ as a physician is something that we do not want because it is translated as having poor coping mechanism, which leads to depersonalization, depression, and finally burnout. All right, so Yerkes-Dodson law has been described early on in 1900s. So this graph actually represents the increment of pressure and how it relates to performance amongst physicians. So having low pressure is not good as well, because that would actually lead to complacency and laziness. We do need a bit of cognitive load and pressure for us to function optimally as physicians. However, if this becomes too burdensome, it leads to reduction in performance that may lead to cognitive and decision-making errors. So how do EI or EQ helps this? By becoming a performance bridge to help you to ensure that you have the rationality as a good physician when managing cases. All right, so how do we think it's divided into these 2 components? So the first component is your intuition. All right, so when you are being faced or encountered with familiar situations, you would know what to do. But this usually can also be dangerous if you are only referring to the schemas that you have in your mind without having any analysis about it. So we learn through analytics when we have cases that are uncertain, when you are faced with unfamiliar situations. So this combination of thinking system 1 and system 2 in balance would actually lead to a very rational decision-making, reduction in medical error as well. All right, so a little bit about the neuroscience in acute stress. So when you have acute stress, of course, I think everybody knows our catecholamines will increase, our cortisol will also be increased, and this will actually impair the function of prefrontal cortex. So prefrontal cortex is important in making executive decisions. So when this reduces, your amygdala or your limbic system or your emotion system will be overridden or be uplifted. And when this happens, you tend to be more emotional in making decisions and ignoring the rationality of your executive decision, because your working memory will also be limited. All right, so why do physicians make mistakes? Of course, burnout is a silent, systemic, and very dangerous. All right, like I've mentioned earlier, the neurophysiological stress response, that is one of the contributing factors. Physiological and human limits. As physicians, we work around the clock. So sometimes we have fatigue, sometimes we have sleep deprivation, and this will actually lead to cognitive error or cognitive overload. And if you have reduction in emotional intelligence as well, or deficits, this will actually contribute to physicians making mistakes. All right, the unwanted complications, as we all know, patient's care will be impaired, healthcare system will be overburdened, physicians' health ultimately will also be deteriorated. All right, so sometimes physicians will actually resort to substance abuse, depression, all right, poor self-care, as well as motor vehicle crashes that has happened many times in our country. Okay, what are the strategies, if I could share a little bit? All right, so I've categorized them into different categories. So what about self? So starts with ourselves. So it's always easier to manage a case when you have algorithms, when you have memory aids, when you have calculators. So don't be shy to use this, all right? It's not like we can remember everything under the sun, even though we are already physicians. But it's important to have reminders. So these reminders will help to reduce in our cognitive overload, all right? So next is front load to unload. So pre-learn, build your own schemas, rehearse your own scenarios, listen to podcasts. I love to listen to podcasts when I drive before work, you know, on certain topics. So these particular topics will actually give me some ignition before I start my shift. All right, so reboot before your shift. As a Muslim, I like to pray. I like to, of course, ask God to guide me during my shift, all right? Meditate, ensure you have enough sleep. And what's important is sometimes don't just go to work with an empty stomach. You need to hydrate yourself, actually. As important as that would actually help in managing overburden of cognitive load, all right? And tune up your equipments, all right? Your fitness, your mental support, that is actually very much needed. Sometimes doctors tend to forget about their own fitness and accept your limits. It's not that we can know everything. We need help. We need a team to actually remind us and help us to prevent cognitive fatigue. So what about the workflow? So when seeing a case, touch it once, complete the task immediately. So that is usually the problem with emergency physicians, because we see different cases, a myriad of different cases at the same time. So sometimes we tend to multitask. Even though we have to multitask, but we have to complete the task at hand thoroughly, because this is to prevent any mental taps that you might have later on. All right, so, and also use the when, then, and if, then rules. So speak to your team. Ensure that you verbalize the complications that may arise when seeing a case, all right? So that everybody is aware of what we are expecting on the next few hours when we see that particular patient. And what about team and communication? So this is all about EQ. When talking, I find it very helpful to talk it out loud when managing a certain case. Verbalize your thinking process, because everybody can actually hear whatever you're trying to say. And this will actually promote a shared cognition as well as a feedback loop in your team. Use checklists as much as you can, because this promotes consistency as well as safety when managing these cases. And debrief your team, because this is the only time you can actually acknowledge and thank your team members, as well as promote what improvements that we can actually do and learn from seeing that particular case. All right? About organizational, so it's a little bit difficult to control patients' volume, but if you can, we have a redirection policy, for example, in the emergency department. So where we don't see the mild cases in hospital, we try to redirect them to the community health clinic, because we need to share the cognitive load overburden with other specialties as well. All right? If you have enough capability, so change the electronic medical records design based on what the physicians actually need, based on your specialties, all right? And formal training program shouldn't focus only on clinical improvements. It should also be human-centered and cognitive-centered. So have programs that promote soft skills and teamwork communication at the same time. All right, as a conclusion, stress actually weakens the brain's reasoning center, because it leads to shortcuts as well as biases or heuristics that you do not want. You need to be analytics. Too much of cognitive load would actually lead to more medical error. So emotional intelligence is not just a soft skill. It is a superpower that you can actually use to help you manage this overloaded of cognitive load. All right? To deliver your best care, you need to have a balanced pressure between smart thinking and your emotional control. And finally, what does high performance as a physician mean? It's basically you have cognitive clarity, you have emotional strength that promotes to better patient outcomes. Right, these are my references. Thank you very much. If you have any questions, feel free to drop me an email or connect with me through Instagram. And just as a promotion, we are having a TopCom conference in July in Kuala Lumpur. So all of you are welcome. And we also have the fellowship in disaster medicine with the New York State University, if you'd like to join. Thank you very much.
Thank you very much. Thank you. Thank you very much. Can you hear me? No. Yeah. They are not. They are connected.
Now it's working.
Have you got any questions? Sorry. Yeah.
Dr. Prabha.
The definition and the underlying problem causes and your solution, great. Thank you very much. It was fantastic. The thing that I want to mention is that I think this is not a problem for only just emergency physicians. It's right, we have such problems and much more than these problems, but this is not just for us. And it deserves to work much more on this issue for us. And I think we need to focus on positive sides also. It is not need just to focus on negative sides. It is really, really very serious and very crucial to focus on positive things, because otherwise the next generation, upcoming generation, they just focus on this area. Emergency medicine is very difficult, cannot be done. So this is a big problem for them. When you ask the next generation, no, emergency physician, it is very difficult. It cannot be done. And it destroys my life. That's right, they have problems. We accept it. We accept it, but we have other sides that can make us very satisfaction. We may focus on this issue. Thank you very much. This issue is really very important, and I like it very much. As I said, it deserves to work, to talk much more on it. Once again, thank you very much.
Thank you, thank you.
Thank you.
There's another question.
Yeah, please. Dr. Alvin.
Thank you, Dr. Jamal, for the lovely presentation. I just like to share, and I like to ask the audience, what is the coping mechanism that we have developed before COVID-19, during COVID-19, as well as the future? What are the changes that we have made ourselves in dealing with current and future crises? Perhaps Dr. Bashir, Professor Altani, maybe the chair like to share to open a light up and give your opinion. What will be the future strength for our young EPs?
You put me on the spot, but we did actually a study on burnout for cross HMC. 2 departments chair refused to allow the physician in their department to contribute to the study because he's concerned about actually the result. One of them is the emergency department, and the second was the anesthesia department. The burnout in the trauma team is 65%. So it's quite high, and I think emergency is not far from that. What is the mechanism that's being done? Well, when we look at North America, there is a lot of actually nurses, especially nurses, decided to quit from centers that work. I know from, for example, in Hamilton, a lot of nurses quitted their job and signed for a contract job, rather continuous, because the stress related to it and also the lifestyle changed during the COVID, which happened for them. In our area, is the system is the problem. And the system, there is a very difficult to change the system. And usually what happened to your case, if it goes to AMOC or M&M discussion, most likely this physician will be blamed because he did not manage on a timely fashion the two cases. And in reality, we have to address the system which resulted in such condition. And that system is very difficult to address in general. So what we learn that when the system under pressure, your performance usually decrease as a system. Individuals, it varies, as you stated. Some people have a lot of tolerance and they can actually adapt for even the largest capacity possible, but these are exceptional. And unfortunately, this is something that you cannot transfer as a knowledge. Most of the time, people need to go through a system of changes before they reach that stages. So to have a short answer, I think system need to adapt, individual need to be looked after in the system to make this attractive, because the new generation think about the three things: lifestyle, income, and then the workload, which is very important. And therefore, in surgery, for example, we have difficulty attracting especially the best or the good resident in the system, because they say, why? Dermatology, plastic, family physician, they have a better lifestyle, same income. So that's my take.
Yes, I recognize that also. Yeah. Thank you very much. Very nice. Now, so I recognize that also in a European setting, 1 in 4 young trainees developed a burnout, and we do lots of questionnaires, research, and also lots of mentoring to help them go through with this. And the healthcare system is, our ministry is like a huge tank which turns very, very, very slowly to go in the right direction. So you're right, I think the system. And also, what I missed in the whole talk was satisfaction. I mean, we are doing our job is helping people. And helping people can give you lots of satisfaction, which can keep you also afloat, you know, in a situation. But I missed that in the talk, but there were lots of other things which I learned. And how we should go about it, what I do is, I got 10 PhDs and also about, I think, 13 fellowship trainees. I always tell them, if you're not happy, always talk to us. But the problem is, when I tell them my door is open, they never come. You got to ask them actively. So I used to tell them 10 years ago, my door is open, always open. Either they didn't come or they came late. So what I do now is just try to talk to them, ask them how they do, and the first initial sign of stress, try to do something about it.
So,
thank you. Yeah.
And the last topic, and also an interesting topic from Professor Dr. Prabhat Nanayakara from Amsterdam. As the head of the team, he will present in place of Nuka. The topic is Snapshot ED, International Flash Mob.
Nuka is unfortunately a bit sick, so I'm going to do the talk. Since we do it together, I can just, it's about the flash mob study, which we are going to perform with you, hopefully. I want to talk about that. It's called Snapshot ED, which we want to perform under the auspices of ICEM.
And I will talk about the rationale, the goal, the protocol, and also the next step. We just had a talk about the acute care chain. We talked about the ED all the time. But most of the problems at the ED is caused in front or because there's no beds and you cannot admit the patients. At least in our setting, we did a Prisma analysis on our patients who stayed at the ED for longer than 6 hours. What we saw was the most problems were post-ED. Either we didn't have beds, either the specialist who had to take care of these patients in the clinic were not involved earlier, either the intensive care was blocked. So ED is not standalone system. This is England. In England, 1.5 million patients wait for longer than 12 hours per year, according to their own statistics. And the longer they wait, the higher the mortality when you compare it to patients who leave the ED in about 2 hours. So it looks like we are leaving the vulnerable patients long at the ED, and because when the patients stay long at the ED, they definitely get suboptimal care. There's also a higher chance of dying. This is the situation in UK. If you look at Dutch situation where I work, we see about 1/5 of number of patients the UK sees. The largest Dutch ED sees about 30,000 patients a year. Average about 20,000. Most of the patients who come to the ED has seen the GP, and GP refers the patients to us. In my ED, the GP post is integrated here. So when a patient, a walk-in comes, he or she is triaged by the GP triagist, and about 10-15% of these patients, from the patients who come walk in, GPs take over more than 50%, which is significant, which means that we at the ED have a pretty normal life because we don't have patients in the corridors, we don't have patients waiting for longer than 12 hours, only exceptionally we have it. So there are lots of, and you know, when you say ED studies, you don't know what you're talking about because every country had their own systems, have their own problems. So that's a problem. So we thought there are no international large-scale studies just to see what's the difference between the EDs. Just epidemiology of ED presentations. We know that if a patient comes with shortness of breath, they have a pretty bad prognosis if they are old. And if most of the patients come with abdominal pain. In the Dutch EDs, it used to be trauma. Now, about 66% of the patients who come to Dutch EDs are non-trauma, elderly patients with problems. They have atypical presentations So what we want to do is we want to see the differences in ED operations, patient demographics, outcomes if possible, and resource utilization. And we want to do this study across multiple countries over 24-hour period. And herewith, we could see whether we could learn from each other. Let's say, how's the system in, for example, in Qatar or in Malaysia? What's the differences? Do we see any differences in the results, the outcomes? Can we learn from each other? We know that the Dutch system where I work, the strongest point is the GP service, which is pretty good 24/7. Any patient can call the GP post, and if they have an emergency, within 30 seconds, the telephone has to be answered. So does it contribute to better outcomes? What we want to decide to do is a flash mob study. We collect as much data as possible in 24-hour period. We want to do it 1st of October, 8 a.m. to 8 p.m. 8 a.m. next day, sorry. Local time. Flash mob concept, we have tested it many, many times. Flash mob is, you know what a concept is. A group of persons come unexpectedly to a public place, do their act, and disappear. And that's the same thing what we are going to do. We asked the doctor to do the same thing. Have we experience with it? Yeah, these are some of the flash mobs which we did. This was with 7 countries, including Hong Kong, where we just asked the patients, what's most important to you during the presentation to the ED and why? Most of the patients say, I want to get better, but when you ask why, because I have to take care of my cat or dog or my grandmother or my kid. And this is the first one we did long time ago on capillary refill time. We have done a large flash mobs about sleep quality in the hospitals in the Netherlands. And we also, on the basis of that results, we did randomized control trial, and we are now doing a national sleep consortium and starting a large nationwide implementation of improvement in sleep. So, what's the advantage of this flash mob study design? It's less time consuming. You don't need to collect patients for months or years. It's less costly, and multiple hospitals can do it at once, and therefore you can create lots of data. So collaboration is the key. What are we going to study? Just going to simple timer presentation. How did they come? Was it critical care or not? What was the triage groups? Demographics. Were there patients about 70, between 60 to 70? Were there kids? Chief complaints. We will come up with a standardized list of chief complaints. Attending physician specialty, because some countries have ED physicians only treating these patients. Some countries have, like in Netherlands and also some other European countries, the specialty can also see their own patients at the ED. So open concept ED and a closed concept. Is there a difference there? Length of stay. Where do they go? A little bit of staffing levels. And if the length of stay is high, why is it? Is it a bed problem, or aren't there doctors? So what we're going to do is we are going to centrally coordinate this from the Netherlands. There are teams. Amber is here, and Nuka, I don't know where she is, but Nuka is there, and Siham is there, and they will coordinate it also with us. And we need one coordinating researcher per country. 2 can also. The coordinating research has to recruit as many hospitals as possible within their country, and the hospitals has an ambassador who coordinate the research project. So 1 ambassador per hospital. We have got the ethics approval now, which means that we can go and send you our approval, and you can also go ask for ethical approval to enrolling patients and everything. And you need teams, and what we did was in our the previous flash mobs, we had teams of students, interns, young doctors, specialists ready to just get this data as easy as possible. We do it also, this is a consortium in the Netherlands, we do it with them, but we can always collaborate with your national consortiums to get it done. All these people can be at the publication, because we can do a group publication, and every ambassador has a publication also, or in principle in PubMed. This is the team from the Netherlands. Nuka will be coordinating it. Sheena is at this moment not there. This is Kauta Asaili, who is an ED doctor at our place. Now, Amba, I told you, Siam, you know. And also, at the moment, these are the names from countries which will participate. And we would very much want to encourage you to spread the word and send us to this email address the country which you want to participate, and also please advertise it. We will help you. We will send you folders. We will make communication material also and more information. And hopefully, this will be one of the many which we are going to do in the coming years. That's my story. And if you have any questions, I'm more than happy to answer. Oh.
Thank you so much, Professor Prabhat. Is there any question for this interesting study plan? It seems so nice.
Yeah.
Thank you very much. It's not a question, but I want to make a statement. I will give an example from my country. We have a population of 85 million, the Turkish population. In 2024, about 45 million have never gone to doctor. The remaining is 40 millions. How can you imagine about the admission in 2024, just for 20 million? We have over 1 billion and 100 million admissions to doctors. This is just for 20 million, to 40 millions. It's a problem, not just a problem, this is a disaster. As you mentioned, every country have different problem and they have their different system. Thank you very much, just before your nice presentation. I like it very much. You gave some example from the United Kingdom. I have never been there, but I think it is not a good example for me because the patient has to wait for a long time. My question is that how can we make solutions? Why does a people need to go to emergency department? I think this is the main questions. What make a patient to go to emergency department? In my country, as I give the numbers, I give the average. About 60% of these patients admitted to the emergency department, over 60% of them, they are very mild category. Very mild. So there is no need for them to go to the ED. But the remaining is okay. Let's get a question. Why does a people need to go emergency department? If they are not severe or moderate, why they need to go? I think this is the system. If the system of countries open a door for them, it's okay for you. Anytime you need, anytime you want, you can go ED. This is the problem of the system that make us exhausting.
Yep.
But they opened all the doors, but the supporting is very weak. It's really very, very weak. And when I come back to my question again, if you want to make a solution, you give the mortality of the patient waiting for a long time.
Yes, we will take that question. That's a good question, Nuka. We got to take it also in the questionnaire. What you said, Holland has 18 million population. We have 1.9 million ED presentations. 1.9 million ED presentations, and it is decreasing. And if UK is 40 million, I think, and they have about 4 times as much, 11 million or something, or 12 million. And every patient in the Netherlands, even when they go to the GP, can call a line or go to the internet and ask their questions, and they get an answer whether it's advisable to go to the doctor or not. Don't get me wrong, if you're having a chest pain and if you're scared, you just go to the ED. It's not closed. So I think the primary care is also pretty important. But what we want to do is see what the differences are, and later stage we can go to the outcomes, because to do the outcomes in one day, it's going to be difficult. Any other questions?
Is there? Yeah. Yes, there's one more.
Thank you for a nice presentation. One of the major concerns in the emergency department is the surge capacity and the time difference between daytime, afternoon and nighttime. And in Malaysia, we have, throughout the day, it is so busy because the primary clinics only function until office hours.
Yeah.
And then the emergency department takes over. But what happens is the community always abuse the system from 24 hours. And now the question is, in your opinion, by doing a lot of studies related, so there are so many studies have been done from triage and then length of stay, pre-hospital care, and then diversions, reverse triage. We have done all the studies. Now the thing is, in your opinion, will the artificial intelligence, AI, in future, will it help reduce the workload at the emergency department and support the hospital? Thank you.
It will reduce the workload if you use it intelligently. You know, too much intelligence is never bad. The question is, if you keep what we do the same way and introduce artificial intelligence, it's not going to change anything. And even autoscriber, you know, there's a scriber now. When you talk, it writes down. You don't have to write down anything. Even that you need to check, you know. So, if a radiologist, let's say they have 100 chest x-rays, 90 is normal. If the AI can say 90 is normal, don't look at it, that will save lots of cost. And what we think is that AI, to triage, it will help, especially at home, if the patient says this and that. And if AI can communicate and ask, have you got this or that, then you've got to go to the hospital, that may help. But the problem is, what are the false positives? So the positive predictive value is going to be very, very important. We do now AI real time. What we see is that people think the same way. You know, you can't have artificial intelligence and human stupidity at the same time. You need to, you know, you need to think intelligently and use that artificial. So eventually it's going to help. But in the next 10 years, it's going to be a struggle to get it implemented.
Also,
any other questions? Okay.
Last opinion from me, Dr. Prabhat, here.
Yeah.
I think it is the variety of countries and variety of health services. Maybe your results will show us, will detect the true one. So, because Professor Behçet mentioned about the Turkish system, in Turkey, the health services are free, and doctors don't have any right to refuse the patient.
Yeah.
So we are so crowded. So the average waiting time before the doctors in the EDs maybe less than 30 minutes. So there are some good parts of these results, and there are some negative parts there will be, you will detect. So I hope you will have a good results with your study. And is there another question?
But you don't forget that politicians love ED physicians, because you do lots of work. They don't have to pay the GPs, they don't have to pay the SIP systems, as long as the EDs just do their work, you know. So in England, for example, the ED system doesn't cost much, but they do a lot. So, you know, ED physicians are a blessing to the politicians. So if you have no other questions, we had 3 presentations. The 4th is not there. Thanks for taking. Thank you
so
very much for taking over. And thanks for your questions. And have a great evening. Okay? Thank you.